Dear listeners and Facebook viewers, we greet you with the greeting of Islam. Assalamu alaikum wa rahmatullahi wa barakatuh, and welcome to another episode of The Health Break. I would like to welcome Dr. Wafa Samen to our studio. Dr. Wafa is an accredited specialist obstetrician and gynecologist, as well as infertility specialist, over 30 years of experience, alhamdulillah. She has a special interest in recurrent miscarriages, polycystic ovarian syndrome, and menopause, and has completed her master in reproductive medicine through the University of New South Wales. Dr. Wafa gained her initial degree in medicine in Iraq, where she then specialized in obstetrician as an obstetrician and gynecologist. After moving to Australia, she continued to be trained in this field. Dr. Wafa has also trained extensively in reproductive medicine at Westmead and St. George Hospitals. She is a fellow of the Arab Board of Obstetricians and Gynecologists and speaks fluent Arabic and Turkish. Dr. Wafa Samen is practically sensitive to the need of our Islamic community, and she is a great asset to our community with her care and profession. Her continuous support to the Quran Kareem Radio of Australia is highly appreciated, and it gives us a great pleasure to have her with us today. Welcome, Dr. Wafa. May Allah subhanahu wa ta'ala reward you immensely.
Thank you. Thank you very much for this nice introduction, Abir. Thank you.
Thank you for being with us. Dr. Wafa, we will be discussing gestational diabetes, and we will be also talking about your latest achievement in infertility specialist, as a specialist in infertility. So we'll start with the gestational diabetes, please. The first question that is often asked, who is at risk in having gestational diabetes, Dr. Wafa?
Now, gestational diabetes is now the highest incidence of gestation of diabetes among all diabetes. You know, we have three types of diabetes: type 1, type 2, and gestational diabetes. Right. So the highest incidence among the population is gestational diabetes, which means pregnant women get diabetic. Now, and this incidence has increased dramatically. Now, the incidence in Australia is 14%, which means 1 in 7 pregnant women gets gestational diabetes.
That's pretty high.
It is very high. Now, they ask me who is at risk of having gestational diabetes.
Yes.
Now, then you ask me, why is this incidence very high in Australia? For a few reasons. One of them is advanced maternal age, which means people now trying to get pregnant, not at younger age as it used to be, which was average age 26, now has gone up to 30. So women after the age of 30 start sort of trying to get pregnant. So that's had big influence on the increase of incidence of gestational diabetes. And second thing is weight gain. Again, increasing weight before the pregnancy and during the pregnancy has big implication of that as well. And
so obesity.
Yeah, obesity, yeah. And race and ethnicity. So people from Middle East, which is unfortunately at higher risk of having gestational diabetes, and Asian women, Black African, and people with family history, like mothers, sisters, or having a previous gestational diabetes in previous pregnancies, puts them to be at higher risk of having this problem during current pregnancy.
Subhanallah.
Yeah.
Dr. Wafa, what are the signs of having gestational diabetes? What do we look out for?
Yeah, the problem with diabetes, we know that is the frequent urination, thirsty, some of them weight gain or weight loss. These are the normal symptoms and signs which we know about the diabetes. But in pregnant women quite often gets these symptoms. Quite often she feels she wants to go to toilet, urinary urgency, because of the pressure of the uterus on the bladder.
Right.
So, and thirsty, same thing. Pregnant women used to drink lots of water. So all these are not sort of specific for gestational diabetes. And the way we diagnose that through our investigations.
Right.
Now, investigations before, we used, like years ago, we used to do blood tests around 28 weeks.
Yeah.
That was routine in everywhere and on every woman, every pregnancy. We used to do what we call it 50-gram glucose tolerance test. So what does it mean? Around 28 weeks, pregnant woman does this blood test, fasted overnight. So we take two bloods, one before giving her anything, fasted overnight, and second one 1 hour after giving her a juice which contains 50 grams of glucose.
Mm-hmm.
Then they found that is not very accurate, sensitive test to pick up gestational diabetes at earlier stage. Then they changed it to 75 grams, which is what we call 2 hours test. Right. Before we used to do what? Sorry, yeah.
Dr. Wafa, that was given to everybody, like every pregnant woman. Okay, go ahead.
So, see, every pregnant woman, for example, first pregnancy, low risk, no previous problems, and she's not a big woman. So we at 28 weeks we do this test. If this test comes back abnormal, then we used to do 2 hours test. 2 hours test involves fasting overnight, do blood test at fasted stage, then give her that juice contains 75 gram glucose. Then check her bloods after 1 hour and second one after 2 hours from having the juice. Then they found that test is accurate, more sensitive than the 50 grams one. Now every pregnant woman is getting this test. So we're not doing that 50 gram anymore. We're doing this one from the start. Right. Then what we added on that is if any woman at high risk, the one which I just said, which is big women, overweight, family history, or the woman who had previous gestational diabetes in previous pregnancies, then those people will have test first trimester of pregnancy. When she's first booked at the hospital or she's seen her GP specialist, we do that test. If it's negative, normal, we repeat the test again at 28 weeks. So which means we started to looking at to see more accurately what's happening. Right. And then not only that, and those women who are, say, if she patient comes to me, wants to get pregnant from the history, if I know she did have gestational diabetes, I'll do the blood test even before getting pregnant. If she's overweight or she has family history or from those areas, I do the test even before getting her pregnant. So with that, we found we have better control on the gestational diabetes during the pregnancy.
Okay, so now, like, you've diagnosed a pregnant woman with the gestational diabetes. Now, the treatment, what is the first step that you would give her? Like, do you go diet first or straight insulin? How does it go?
Okay.
Or can they take tablets?
Now, if the patient comes to me, it's best thing, of course, to change their lifestyle. If she's overweight, she needs to change her lifestyle, which means change the diet, do exercise. So that really helps to sort of prevent her from having gestational diabetes. But if she develops gestational diabetes, again, we try first diet and exercise. Now, with the diet, we need to concentrate on lean protein and good fat, food with high fiber, and avoid all these fruit juice, anything with such low glucose. We need to concentrate on food which has low GI. Low GI means those food which stabilize the blood sugar better than high GI food. And low GI food, all these like whole grains, breads, all the starch, brown rice, and food with fibers.
Right. Will gestational diabetes affect one's labor or delivery at any stage? Could it cause like a miscarriage or anything like that?
Okay, now, see, any woman who knows she did have like previous So when you say gestational diabetes, which means she doesn't have diabetes, she does develop diabetes only during a pregnancy. So I'm going to concentrate on that. Now,
Right.
if the patient is, like, as I said, overweight, we need to make sure that she loses weight before getting pregnant.
Okay.
And say if she develops diabetes during a pregnancy, yes, there are lots of problems. First of all, if the blood sugar is poorly controlled, in this case, baby will grow bigger. And if it is big babies, then that have like implication during labor, which is could be difficult labor. Baby could get shoulder dystocia, where the shoulder gets stuck under the pelvic bone, and that could cause fracture, Erb's palsy, and then and trauma, birth trauma, vaginal tear, and increases chance of cesarean section. If it is big baby, then we'll have chance of cesarean section higher. And nowadays, what we are doing in Australia, women with gestational diabetes, if they are on insulin, better to induce them earlier. We don't let them to go to 40 weeks at 38, 39 weeks. And if they are well controlled, diet control, again, we don't go beyond 40 weeks, which means induction of labor increases when the patient has gestational diabetes, and all the implication of course, induction of labor. We don't sort of recommend cesarean section for every woman who has diabetes, because if it is well controlled, we don't need to go for cesarean section. We just can induce and try to get her delivered vaginally. Now, on the woman, so what's the effect of diabetes on women? It increases the chance of preeclampsia. Preeclampsia means pregnancy-induced hypertension, and that by itself causes growth restriction, baby's growth restriction. So, and people with gestational diabetes are at higher risk of having pregnancy-induced hypertension, premature labor. So these are all the complications associated with gestational diabetes. This is for the baby during pregnancy, and after pregnancy, after labor, the baby will have like 50% chance higher to be admitted to a special care nursery. Why? Because this baby used to get high level of blood sugar. Now, after labor, baby going to depend on this on pancreas to produce insulin. So they quite often they get low blood sugar, and they need admission to a special care nursery. And this is one thing. Other things.
So this is as soon as they're born, like they're born like hypoglycemic. Like,
we need, not always, depends on the blood sugar level. If the gestational diabetes was well controlled during pregnancy, the chance is lower. But always the nursing staff will keep eye on baby's blood sugar. So keep checking blood sugar for her, for the baby, for the mother. And as I said, will be higher chance of being admitted to special care nursery, just purely to observe blood sugar. And the babies with born with mother who had gestational diabetes, higher risk of developing jaundice. Why? Because will be high bilirubin level. Why would they get high bilirubin level? Because if they have high sugar level, if the baby has high blood sugar level, then they have more prone to develop red blood cells. And for the liver to break all these red blood cells, then bilirubin would be high, and the baby would develop jaundice. And some of them need like phototherapy, admission to a special care nursery to deal with it. Yeah.
Right. Doctor, I'm just gonna go back one step. So, being a gestational diabetic, or having gestational diabetes, regardless whether you're on insulin or on diet control, there's an induction involved. Like you induce the pregnancy regardless. Is that what I understood there?
Now, what happens? See, if she is diet control, and baby is growing well, baby is not big, we can let them go to 38, 39. See, nowadays, practice has changed. Even now, in my private practice, because I do obstetrics as well, I don't let the patient go beyond 40 weeks. I usually induce them around 39, because this is when they don't have diabetes. But if they do have diabetes, my cutoff is 39. Why? As I said, because again, I don't want the baby to grow bigger, and if it is insulin dependent, it will be earlier, say around 38 weeks.
So I just have a question, actually, like that was emailed to me, kind of answered it, but I just, for the sake of someone asked it. So if someone is diagnosed with gestational diabetes, is there a risk in not taking insulin, even though, she's saying that she's reading 5.3 in the morning. So if she does not take the insulin, is that required a risk? And after food, sorry, Dr. Wafa, she's saying after food, like her highest is 6.9 or 6.5.
That's good. That's good. See, anything around 5, fasting is okay. Anything after food, 1 hour after food, around below 7 is good. We accept that. She just needs to concentrate on diet, not insulin.
Now, when you say after food, Dr. Wafa, like, are you counting from the time they start food or they stop food?
No, this is stop food.
Stop food. So if I'm having breakfast at 8 o'clock, I finish breakfast at 8:15. I will test at 10:15. Correct?
Exactly. Yeah.
Okay. Thank you for that clarification. That was a question actually was asked there. Also, there's another question. Will a person continue to have diabetes or necessarily continue to have diabetes after having gestational diabetes in any check?
Okay, let me just clarify this one. They said 5% of a pregnant woman who did have gestational diabetes will have diabetes, type 2 diabetes, within 6 months after having a baby. That's 5% within 6 months, but 60% within 20 years. See how high is that?
Mm-hmm.
Yeah.
Wow.
So 5% within 6 months and 60% within 20 years.
Wow.
And not only diabetes.
But there is also a chance that they can never develop type 2 diabetes.
Okay, all depends on what? On changing lifestyle.
Right.
That's why I really don't encourage people to go for gastric sleeve operations, all these. Why? Because if I don't change my lifestyle, if I don't train myself to eat sensible and healthy food and do exercise, that by itself, losing weight from operation doesn't help in long term.
That's right. We should have the willpower ourselves and do it on our own. It's of course much healthier and much better. Dr. Wafa,
I want to add that this point
is
not only the pregnant woman, even the babies who born to a woman who had diabetes, they are at higher risk of developing type 2 diabetes in the future.
Right. Thank you so much for clarifying that. So we have to be very careful
not to be selfish, just we have to look after babies in the future as well.
Absolutely. You've cleared many questions, and as usual, it's always a pleasure having you. I just want to touch base on your specialist, in which you highly concentrate and put so much effort since 2006, and that is the field of infertility. So if you can please, as a specialist, fill us in there with a bit of information. What is the latest there?
With infertility, see, this again, the incidence has gone up really dramatically. Why? Again, 10 to 15% of couple, we don't know, it's unexplained, but the rest of it could be either maternal woman, again, age and weight, that has big implications. So now I work with IVF Australia, and we opened a low-cost clinic at Liverpool. So probably people need to know that, because it is low-cost clinic. Absolutely. It is run by 5 specialists. We work at Westmead with IVF Australia. We run that clinic. And no waiting time and no trainees, and the cost is so affordable, which is I'm going to tell you how much going to cost. If the patient does not have healthcare card, would be $1,500 out of pocket money. If she does have healthcare card, only $800 out of pocket money. That's first cycle. If it doesn't work, subsequent cycle for healthcare card holders only 400, for non-healthcare card holders only 700, and that's to cover everything, the cycle, medications.
Subhanallah.
How good is that? We're so lucky in
MashaAllah,
this
that
country.
is so, this is a blessing from Allah subhanahu wa ta'ala.
Yeah.
May Allah subhanahu wa ta'ala, you know, have it in your mizan hasanat. This is a really good news. So in other words, there is a refundable amount if it doesn't work, you know, like for them the first time or whatever. Good.
Just repeat it, yeah.
Dr. Wafa, could a person not have a chance in you know, in carrying, like and how do you indicate that? I know this is a huge avenue to discuss, but can you determine that you know, after so many tries, or like it takes a long time to determine?
See, the thing that with IVF, like we use different protocols and like different doses. If the patient, like we say, for example, of course, always first cycle, we use our standard protocol, which is, just give you an example. This patient is 25-year-old. She's fit and well, not obese, and all good. And then if I started, we say Gonalef 150. That's our standard
Right.
dose. If she respond really crazy to this dose, I'll go next cycle reduce the dose. If she did develop poor response, I will increase the dose. This is how we look. Say, for example, if the patient like not responding, how do we know? Like either eggs are poor quality eggs,
Right.
or maybe we need to either change the protocol. But again, your question is whether do we know? Yes, from a few cycles we know what's going on. And
Right.
generally speaking, if they are young, they usually have good quality eggs. Always comes down to eggs quality. Of course, the sperms are important. But when I go to the sort of doing IVF, in this case, I have a few ways of doing it. If the sperm is poor quality, we go for ICSI, which is mean injecting each sperm to each egg. And if the sperm is really bad quality, in this case, we have a special microscope, we call it, which is, we call it high mag, which means that special microscope magnifies that sperm to 7,400. The normal one only 400. So with 7,400, then we choose the best of the worst. That's how it works.
Subhanallah. It sounds, you know, subhanallah, it sounds amazing, you know, like how all we can say is pray for you. May Allah subhanahu wa ta'ala give you the, you know, more of the knowledge and more of the techniques and more of the light to see and help others that have these issues and these problems. Jazakumullah khair, Dr. Wafa, for being here with us today. It's been a pleasure having you, and we promise, inshallah. I mean, you've never returned a request to the Quran Kareem Radio. You've never said no to anything. We appreciate all your time and effort with us, and inshallah we'll have you all talk more about all the things that is involving women in particular, inshallah, and women's health. And we took some time out of your weekend today. We appreciate your time, and may Allah subhanahu wa ta'ala have it in your high level of scale of good deeds, inshallah.
And thank you very much for having me. Thank you.
Thank you. Thank you, Dr. Wafa. I would like to thank Dr. Wafa Samen for being with us today, and may Allah subhanahu wa ta'ala reward you immensely, like we said. And we look forward to having you again with us and on many other talks to tackle other areas, inshallah. Dear listeners and viewers, you can send your questions and suggestions and feedback by emailing the health break at qkradio.com.au. Until we meet again, we leave you in the protection of Allah subhanahu wa ta'ala, and we say, Assalamu alaikum wa rahmatullahi wa barakatuh.